enigma, be it a phacosurgeon or a femtosurgeon. For everybody it used to be. But now, as you can see in this, what has happened is that I've started with this, the routine procedure, and when you're doing the manual capsulorhexis, and with the white cataract you reach this situation. This is a situation which can cause a lot of problems. So this is one concern for those who are doing phaco, that should we go ahead with phaco and all, or can we use better options? The next is a situation where the CCC created by manual capsulorhexis is eccentric. When it is eccentric, we reach a situation where we can have problems. As you would find in this patient, everything was moving around fine when suddenly I found, to my dismay, that the capsulorhexis suddenly, with this separation, it extended here and it extended to the periphery. So when you have capsulorhexis extending to the periphery in mature white cataracts, it's a concern because the capsule can go back. There are other situations in which you end up with a smaller capsulorhexis despite all your efforts in mature hard cataracts. So for phacoemulsification, where you need a good capsulorhexis, where it was a big mental block for us when we started doing, femto cataract, whether we'll be able to do capsulorhexis with this or not. Well, that was which you will see in the next videos, how we can get out of these problems which exist with manual capsulorhexis. This was the first case where I started. That was 2.5 years back, where I used this femto for mature cataracts. I do stain them, quite contrary to what Dr. Ganesh said, because I want to visualize the capsulorhexis fully, and in this since it was the first case and I was not sure whether the capsulorhexis would be complete or not, with the older version where the capsulorhexis were an issue, I could still make a free-floating capsulorhexis. It is thought that you are not able to make partial fragmentation in mature cataracts. But contrary to my expectation, in this particular case, I saw that the partial fragmentation, as you would see now, was possible even with a femto laser. I went there with the thought that it would not be there, but suddenly I found that I was able to, not in this, because that was the first cut in which I was not very sure, and then I found that the partial fragmentation was already there. So in mature cataracts, in some situations, you are able to have partial fragmentation with the femto also. So this was the first case in which I did, and that gave me a confidence to move ahead in white mature cataracts for doing femto cataract surgery. Moving on to the next one. This is the one in which the anterior capsule is fibrosed. So these are some situations where you feel whether you would be able to have a circular capsulorhexis, because at times when you are trying to do a circular capsulorhexis with the manual one, there is a predisposition for the flap to extend to the periphery. In this case, when I tried it on the fibrosed anterior capsule, and I found that I could make, as you will find in the next video when I took the patient to the OT, that this is the one in which it was fibrosed. As you can see, that fibrosed material, I stained it, I do stain it. I was a bit careful, but then I found that I could remove it without any hassle. However, in this case, I could not have any laser effect on the nucleus. So the nucleus fragmentation was done by me with a direct chop method, and I could complete the procedure without any hassle. In this case, the reproducibility which the femto laser offers with the with a 5 millimeter capsulorhexis made a situation easier for me where I could do emulsification in such hard cataracts without any problem. So as you can see now, it is fully divided. I'm using it as I use the normal phacoemulsification procedure without, however, in this case, without the aid of any femto laser fragmentation. This is another one in which it was intumescent. Here, I do stain it again because I just want to have a good feel, a good visual see of it, visualization of the capsule flap. And here also, it was practically possible to complete the capsulorhexis without any hassle. The fragmentation in this case also was not absolutely there. So I had to, I think there was some bit of it when I retrospect, but it was not as it usually is with the other grade 1, grade 2 or grade 3 cataracts. This is the one in which I found it was a Morgagnian cataract, and this Morgagnian cataract suddenly, when there was an opening and there was a blast. So this was basically, and when I took the patient around, in this case, as the fluid comes, you would not be able to do any partial fragmentation of the nucleus. So that was not possible in this, but then the incisions and everything were possible. Now this is how the patient came into the OT. And there was no issue whatsoever with the incision. Now I'll be, I'm using the cystotome, and with the help of the viscoelastic, and then I'm not usually using the cystotome, but here I usually do it with the capsulorhexis forceps. I could do it without any issue. The fragmentation was done since in the routine manner, but since in Morgagnian cataracts, partial ones, as it was not a fully developed Morgagnian cataract, I continued with the phacoemulsification in the normal way, and this is the the pointed chopper, which I feel is a big help for doing phacoemulsification or the chopping off very hard nuclei. This last video after that, which I will show, is also another one, the initial one, in which there were capsular adhesions. I used you can see those conjunctival hemorrhages in the initial cases, and which was more profound when we were not fully aware how to take care of them. Now with the lesser, here you can see there are some tags. So these tags, I'll use the capsulorhexis forceps to my advantage to take care of that and get a nice capsulorhexis to my advantage, which at times is not there when I'm using the manual capsulorhexis. Now with the capsulorhexis forceps, I know where the adhesions are. Without any hassle, I'll move it and I'll be able to do the surgery the way I would like it to be done. Thank you again for it. But I would like to say one simple and small thing. Fortunate are the surgeons who have evolved from ICC. Dr. Keki is there, Dr. Noshir, Dr. Graver to some extent, and myself when in 1985-86 I used to see ICC to, you are in the younger brand, sir. you are so fit that I would say that you are much younger. Yeah. ECC to phacoemulsification and now to femtocataract. Well, the query is, will femtocataract take over? Well, that time alone is going to say. Thank you very much for your kind attention.